The second lecture is on tuberculosis, and hopefully we'll get to cover leprosy as well. So that's just to show you the running order and the goals of these lectures. Facebook, because just to remind you. So let's now start with tuberculosis. So what is tuberculosis? It's an infection, usually of the lungs, although it can affect many other different organs as well. It's caused by a particular bacterium known as Microbiology tuberculosis. And most of the infections across the world are what we call asymptomatic, or latent. They sitting there doing nothing, not bothering the individual, but there it is, growing, multiplying in tissues, but not causing disease, or sometimes not even multiplying, just sitting there inactive. About 10% of the cases actually go on to active disease. And this active disease is often described as having the quartet of tuberculosis, which is fever, malaise, night sweats, and weight loss, tied in with a cough and what we call in the jargon hemoptysis, which means coughing up blood. So you get a cough and then you cough up blood. You get all those other things. And if it's not treated, it can be fatal. Now, in 2007, there were supposed to be around 14 million chronic active cases, about 9 and 10 million new cases, and getting on for 2 million deaths around the world. And worryingly, there were also around 500,000 cases of multi-drug resistant TB. That gives you a kind of idea. Now, in terms of where did TB come from, this is still quite a hot potato. Various papers here looking at detecting tuberculosis in ancient bones, going back to, well, if you saw Alice Roberts on television last week, back to Homo erectus in some cases. There are arguments about whether this organism originated in East Africa and then spread with humans throughout the rest of the world. We know there's clearly a bottleneck that Mycobacterium tuberculosis is actually a very homogeneous species, and perhaps that was derived from just one lineage. There's been these very early diverging lineages being discovered in East Asia. David Minikin, who works here in Birmingham, has actually found tuberculosis remains in bison bones that are 17,000 years old from North America, so predating the arrival of humans in North America. And so I think it's quite hard to actually come up with any definitive answers to how TB came about. One thing we do know is that if you look at the bovine form of tuberculosis, which is in the news a lot at the moment, with this badger cull and so forth, until people started sequencing genomes, they thought that we caught it off the cow, and the cow was the original host. It seems that it's the other way round, that the cow version is actually a cut-down version of the human form of the tubercle bacillus, and that it's likely that we gave it to cows during domestication rather than the other way around. Of course, humans can now catch it back off cows, and off of milk from cows and so forth. That's why there's so much fuss about it. But, so in terms of its effect on history, well, devastating. 1 in 5 people were dying from tuberculosis 100 years ago. There's George Orwell there, there's Keats, the Brontes, Kafka, D.H. Lawrence, Chopin. All these people died from tuberculosis. It was, in some senses, a tragic disease of tragic, arty kind of people who died from tuberculosis. It was a kind of noble thing almost, a tragic thing. Here's a quote from Bunyan, Captain of All, the men of death was consumption, for that was what brought him down to the grave. So it's no exaggeration to say that tuberculosis has actually changed the course of history. This is Muhammad Ali Jinnah during the 1940s. He was leader of the Muslims in pre-partition India. He lobbied hard for partition of the country into a Muslim part and a Hindu part. The Muslim part came Pakistan. If the British and if the Hindus had known that actually he was fatally ill with tuberculosis as he was doing those negotiations, they'd have probably dragged him out a bit longer and things might have turned out differently. As it happens, he died just 1 year or so after Pakistan gained independence. He was very unlucky because he died just at a time when the first treatments for tuberculosis were coming in. So the first randomised trial of streptomycin, which showed that you had an antibiotic that worked against TB, was taken out. Was carried out in 1947. I don't think I'm being too political in saying that actually the course of Pakistan's history after the death of Jinnah was not actually very straightforward or classic. The country didn't do particularly well. And maybe if Jinnah had been around to actually see things differently, it would have been a different outcome. You contrast that with Nelson Mandela, who was diagnosed with tuberculosis at the age of 70 in 1988, and he was treated. Effective drugs existed, tuberculosis got rid of, and he went on to lead South Africa to a multiracial democracy and served as the first post-apartheid president. And then went on in a very inspiring way to actually give up office and allow the democratic process to find a successor. So it's a fantastic example there. And he's still alive. I think he's now 94, isn't he? This is a slightly old slide. So anyway, away from politics and history, back to microbiology. So what about Mycobacterium tuberculosis? Why is this such an odd and difficult organism? Well, it's very different from your average bacterium. It's got very thick, complex, lipid-rich cell walls. In fact, its cell wall is probably the most complex we know of in nature. In fact, here in Birmingham, we have the world leader, a guy called Del Bezra, picking apart the actual enzymatic steps that lead to the creation of that mycobacterial cell wall. These bacteria are often known as acid-fast bacilli, because you can't stain them with the normal gram stain that you use for most other bacteria. You use a special acid-fast staining procedure where you stain them up and then you try and leach out the stain with acid. And for most bacteria that leaches the stain back out again and they don't retain the dye. But with these they are acid-fast, they retain the dye even when you do those harsh things to them. And actually in the medical jargon they're often called AFBs, acid-fast bacilli. It grows very, very slowly as well, so it causes chronic infections, not like having a UTI or a wound infection that's over in a few days or whatever, or a few weeks. These are infections that take decades to run their course. And it's actually a particular hazard in the laboratory environment, in the hospital environment. And so lab staff and hospital staff are at risk from infection here. It's one of those things that we really keep a close eye on. It's also difficult because it's resistant to all the common antibiotics. So you go and get some amoxicillin from your GP for urinary tract infection or whatever. That wouldn't work against M. tuberculosis. And it needs special agents to treat it. It needs treatment for months at a time. And it needs multiple drugs. So we have a similar problem here as we saw with malaria. If you give a single drug against a person with tuberculosis, there is, I don't know, about 50% chance that they will relapse sometime afterwards, months afterwards, but they'll relapse with a drug-resistant form of the disease. And so you have to give combination treatment because it's more effective, but also because it prevents that resistance. It also has a very particular lifestyle living inside macrophages. So macrophages are one of the cells in the immune system that's there to destroy microorganisms. But this particular bacterium has found a way of getting inside them and living there. Antibodies, it just laughs them off, don't have any effect. And so what you need is a cell-mediated immune response for protection against this infection. In terms of natural history, so how does the course of tuberculosis look? Well, start off with this primary infection, which may have no symptoms at all. Or it may be that you just get these non-specific fever, malaise, weight loss, night sweats. There are basically three ways in which you get the infection. The most common by far is inhalation of the tubercle bacilli, and this leads to infection in the lungs. However, you can get tuberculosis from ingestion, and when people used to drink milk from tuberculous cows, this would be a route whereby you could get infection. And there, the infection would either settle on the tonsils and survive the nose, or it would settle into the small bowel and you get mesenteric lymphadenopathy. The lymph nodes there would all swell up. You can also get direct implantation into the skin. So this is a very rare condition, but it has been described. People who do autopsy, post-mortem examinations on tuberculous patients are at risk of this if they cut them through some tuberculous lung and then stab themselves. And in fact, Lenné, who was the guy who discovered this, well, invented the stethoscope, this is how he died. He was doing the post-mortem and jabbed himself in an infection with tuberculosis and died from it. Next we have primary progressive infection. So this is where that infection doesn't just sit down and be quiet for a while, it actually continues to progress. And you get local erosion, you can get dissemination into the bloodstream or lymphatics, you can get then what we call metastatic infection. So you get infection at sites far from the initial site of infection. And the commonest and most troublesome of these is tuberculous meningitis, where the organism finds its way into the meninges and causes a particular kind of meningitis. Most people don't get that if they get infected. Most of them will have just the infection walls itself off and it goes latent and sits there doing nothing for decades. Then what can happen is you get reactivation, and the disease then recrudesces, grows up again and starts being active. So this just shows that kind of progression diagrammatically. So you've got birth, got someone with tuberculosis uninfected, they get latent infection, it becomes latent, or it becomes primary progression, it becomes infectious, or it becomes non-infectious, and going into CSF and they're not really infected. But the latent can then reactivate and get reinfected and then go on to infectious, and then death or recovery, depending on whether you're treated effectively or not. So what does it look like clinically when you actually have active tuberculosis, when your latent disease reactivates? Well, we mentioned some of the signs already: fever, malaise, weight loss, night sweats, cough, hemoptysis, chest pain. On the X-ray, we see what we call patchy opacities in the greyed out areas, mainly in the upper zone of the lung here. And you can see also that there's a cavity surrounded by those arrows there. And that's a classic sign of tuberculosis. So you get cavities formed in the lungs, and the surroundings of those cavities then get calcified, become hard, and you get shadowing around them on the X-ray. And you also get what we call hilar shadowing, which is this area on either side of the heart. The lymph nodes there swell up and make the heart indistinct around all that shadowing there. You can also get something called miliary tuberculosis, where the organism just spreads through the tissues uncontested and settles down and forms lots of little lesions. In the lung, and I think in the liver, they're said to look like millet seeds. I don't know why the old pathologists always used to think of food when they were looking at these things, but they look like miliary tuberculosis. In that case, you see this kind of shadowing all over the lungs, not just in one particular node of the lung. In terms of the pathology of the disease, the hallmark lesion of tuberculosis is something known as the caseating granuloma. Again, these pathologists, how anyone can have food on their mind when they're looking down microscopes at diseased tissue or macroscopic, I don't know. Anyone know what caseation means? It means make cheesy. Caseation comes to that cheese. It's starting to look a bit like cottage cheese. So what happens is you have this granuloma and the centre part of it dies off, and the tissues all break down and form this kind of cheesy stuff. Here is a figure just illustrating the progression here. You have a mycobacterium, gets inside alveolar macrophages, travels through into tissue, settles in there, and the macrophages then start to change their characteristics, and they recruit other macrophages, these so-called phomomacrophages, you get this lesion forming, and then you get lymphocytes on the outside, and then you get this almost this fibrous cuff, and the whole thing then gets so big that it's not got any supply of nutrients and oxygen in the middle there, and you get destruction of the tissues. And then eventually, in the worst case scenario, this thing is actually so big and close to an airway that it ruptures into the airway and releases all those mycobacteria, and then the person's coughing them up in their sputum, and that then propagates the infection to the next unfortunate individual. So how do we control TB? Well, again, it's all politics, isn't it? We eliminated poverty, improved hygiene, housing, diet, and so forth across the world, then a lot of the problem would go away. And that's one of the things that's happened in our own societies. We've seen a progressive decrease in the incidence of tuberculosis in Western societies for around 150 years, predating the advent of antibiotics and predating vaccination. A large part of that was because our stock of humanity was just getting better fed, living in better housing, and so forth. Bovine tuberculosis, well, I'm not going to get drawn into that one. I mean, this is extremely controversial at the moment. Obviously, pasteurisation, controlling your animal reservoirs, are you shooting all your infected cattle? But at the moment, as hottest of hot potatoes, does badger culling actually work or not? Vaccination. So, in my generation, immunisation was carried out with BCG at the age of 11 to 13. Since then, it's been phased out in some areas, retained in others. Some areas have actually had large numbers of immigrants have actually decided to vaccinate at birth rather than at adolescence. So, again, this is an area where it's quite controversial. It's not really a good consensus as to what we should be doing here. And in the US, in fact, they don't use BCG at all. They never have. When we're actually dealing with patients in hospitals, we have to put them in a side room, we have to isolate them. What we call smear-positive patients are the ones that are most infectious. So this means if you do that acid-fast staining on the sputum and you can see the bacteria actually in the sputum without any culture or anything like that, just look down and you see them, they're called smear-positive. Those cases are considered to be infectious. If the patient is actually shedding the bacteria, but you can only detect them after prolonged incubation, then they're called smear-negative, and those are not thought to be involved in transmission. So we do microscopy, culture, and sensitivity testing. And the treatment, what we aim to do is rapidly render these cases non-infectious. So within a fortnight of effective treatment, they shouldn't be shedding TB anymore into the environment. And we follow these up, and this is a notifiable disease in the UK. It's constrained by law that the physician making the diagnosis has to let the local public health authorities know about it, and so that they can then chase it up and look at the risks. Now, just say a few more words about BCG. BCG stands for Bacille Camet-Guin. It's a TB vaccine strain, and it was derived, actually, curiously enough, from a virulent isolate, not of the human tuberculosis, but from the bovine form. And what these guys did was they just passaged the bacterium multiple times on this glycerinated potato medium containing beef wine. So basically found a medium that supported its growth well, and they just subbed it out, leave it for a few weeks or months, get nice colonies, then sub those out, kept doing that. And during that process, it became attenuated. It lost its ability to cause disease in animals, but it was still able, in guinea pigs, for example, to provide protection against challenge with the virulent form of the bacterium. Now, it's amazing when you look back that they managed to get a vaccine like that with these crude approaches, they didn't have any molecular biology, they didn't understand what had happened to this vaccine. It's only really in the last, well, 15 years that we actually have understood the basis of how this vaccine came to be. The vaccine's been given to over 3 billion people. I've had it in my arm. Has anyone here had BCG? Yeah. The problem is that BCG shows variable efficacy, and there have been trials done throughout the world, some of which showed it worked pretty well. An MRC study here in the UK showed 80% protection. But other studies, equally well done, methodologically sound studies in North America, famous study in a place called Chingleput in India, showed 0 efficacy. And so we don't understand really clearly what's happened there. There are various possible explanations. One is that if you live in certain environments, you're actually getting effectively naturally immunised because you're coming across related bacteria in the soil and you're just meeting them in your everyday life. And therefore you can't really improve on that. Whereas in the West, because we're all very clean and we live in this hygienic environment, then maybe we're not getting that. Another alternative view is that actually those environmental microbacteria are misprogramming your immune response. And so exposure to them is actually meaning that you end up making a worse response to TB than if you were naive. So there's ideas out there, but we don't know for certain. There is a risk of something called BCGosis, which you see rarely, but it does happen. It's well described. You see it in HIV-infected individuals. You sometimes see it in those with genetic deficiencies in their immune system as well. So the BCG strain has the ability to replicate in human tissues, but it's normally very, very constrained. I mean, when it's injected, you get a little bit of pus forming, and it goes a little bit pussy and gunky for a while, and then it heals up and forms a scar, and that's the end of it. But in these individuals, it disseminates through the body and causes problems. And so ideally we'd like a better, more effective vaccine, but we don't have one at the moment. In terms of diagnosis, focusing now on microscopy and culture, to say they stain very poorly with the gram stain, so we rely on this acid-fast staining. There are 2 basic methods. One is the classical approach, pioneered by 2 guys called Zeal and Nielsen, where you stain up, like in this top one here, and you can see the TB there, these TB bacilli, these kind of purple rods there. It's this kind of bluish background. You can actually use a fluorescent stain and use a fluorescent microscope, and this is actually more sensitive because then you actually see the bacteria shining out against a black background. So this is the best way if you want to scan large numbers of fields on the microscope to do that. We grow this organism on special slopes called Lowenstein-Jensen slopes. So normally when we culture bacteria, we culture them in petri dishes on agar plates. We can't do that here because it takes weeks of growth and the agar plates will just dry out. Plus this is a very dangerous organism, so we have a screw cap here, so it's all contained and it's all kept in a cabinet and so forth. And so we have this very particular way of growing it. This is a bit like a kind of omelette, if you like. It's a sort of insippated egg medium with malachite green in there and a various other things. And it grows, again, breadcrumb-like colonies. These pathologists are always thinking about food, but they describe them as rough, buff, I should say, and tough breadcrumb-like colonies. There are problems with diagnosis in that you have to think about it before you can get a diagnosis. From a clinic test, I think, this patient might have tuberculosis to send the sample off. In fact, in many cases in labs, they used to culture all sputum samples for TB. I think that there's been cutbacks on that, they always do it, but there are issues there. And obviously delays in getting stuff to the, getting the patient back into clinic and actually getting them treated can also create problems here. An alternative approach to diagnosis used in certain constrained conditions is the so-called tuberculin testing, where you have either a MON2 test or Heath test, where you have this kind of pickled form of the bacterium called the purified protein derivative, and this elicits this so-called type 4, delayed type hypersensitivity. You inject that into the forearm and you come back a couple of days later and you'll look at this lesion here. What you're actually measuring is the hardened area. So you will see an area that's kind of gone red, but if you run your fingers over it, you can feel like a button under the skin where it's all gone hard, and that's what you're measuring. And this is a measure, gives you evidence that the patient has been exposed to the bacterium, either in a past infection, and they may have cleared it, or it may be an ongoing active infection. Unfortunately, it also cross-reacts with BCG. So if the patient's been vaccinated against BCG, you also get this positive result. So a negative result says that they haven't had infection or vaccination has not worked properly. In the US, this tuberculin testing has been used. If someone has been exposed to tuberculosis in a given setting, you can use this to see whether they've actually acquired the infection. You can follow them up with tuberculin testing. But we can't do that here because most of us are BCG vaccinated and therefore positive already. Now, treatment is really quite tricky. You have to use these multi-drug resistance regimens, multi-drug treatment regimens. You have a range of first-line agents which are listed here. Again, this is one of those things where kind of jargon has taken over, and they use these 3-letter abbreviations or 1-letter abbreviations for them, and then you can score up the regimes in this kind of shorthand here. So there's an initial phase of treatment where you give 3 drugs for 2 months, and then the continuation phase where you give 2 drugs for 4 months. So this would be 2 months of isoniazid, rifampicin, ethambutol, and pyrazinamide, followed by 4 months of isoniazid and rifampicin. I think the 3 is actually the dosing regime that you use as well, 3 times a week. Now, one of the breakthroughs in the last few decades has been bringing in this directly observed short course therapy, or DOTS. And this is now what the WHO recommends. It's got 5 components. The government, where you're using it, is committed. It's taken up by the local authorities there. You detect the cases by sputum smear microscopy. You have this standardized treatment regimen, and you get someone to watch the patient take their doses. You have regular drug supply, that has to be in case, and you record everything so that you can assess what's going on. There are concerns with dropout in the last 6 months, and there are concerns about ethics, because basically what you're saying is we don't trust you as a patient to take these drugs. Now that's based on matter of fact, that patients don't comply. You know, if someone says to you, you've got to go away and take these drugs for 2 months, and within 2 weeks you're feeling well, and you can't be bothered to continue taking them, you know, that's why we do it, but it is, you could argue, it's patronising, paternalistic to go, but it seems to be something that works, and it's something that's been implemented. If you've got multi-drug resistance TB in the area, then you have to step up and actually have what they call DOTS plus, where you're using different regimes and more drugs and so forth. So across the world, there's this Stop TB strategy, with the idea that we might have a TB-free world, and the idea they always go for 2015. The world's going to be a wonderful place in 2015 if all of these plans come to fruition, but they want to reduce the global burden of TB by 2015. It's good to aim high, I suppose. I won't read through all of those things, but you can see all the various steps there in terms of the objectives. The bottom one there, human rights, is coming in as an issue. And then this was adopted as a Millennium development goal and as a target for that as well. You can see by 2050 we should have eliminated tuberculosis as a public health problem. I guess there's a small chance I'll still be alive. I'll be 90 in 2050. You will still be middle-aged, and maybe you will live to see that day when actually tuberculosis has been eliminated as a public health problem. So the global plan was launched at this World Economic Forum in 2006, and again, Bill Gates is one of the heroes here. Pledged $600 million towards this. So all those people that made the wrong choice and bought Windows instead of a Mac, they at least have done something good for the world. Steve Jobs was a miserable old bastard. I don't think he gave any money away to charity, did he? Whereas Bill Gates, well, we can justify that operating system by these fruits that have come of it. 56 billion have been allocated, and all these new things coming in. So what are the problems with the current intervention strategies and the global issues that are sort of underlying them? So I'm not going to go again. I'm getting tired, you're getting tired. I won't go through all this. You can read it in your own time. But you can see that there are problems with infrastructure, there are problems with diagnosis, problems of vaccination, problems of treatment, and there are problems of actually finding new drugs and this target-based drug discovery. And again, it's worth stressing the University of Birmingham here is at the forefront of these efforts to actually find new drugs. And we've just invested £800,000 in a drug discovery platform, and we've just been successful in winning another £1 million to set up a special laboratory to look at drug screening against the agent of tuberculosis. The kind of four obstacles, I guess, that are really hampering things and making us not quite so optimistic as we might be. We've got the HIV-associated epidemic, so there's this synergy between the two. Drug resistance TB, need for better diagnostic assays, and limited efficacy. And I think I've got some slides on each of those in more detail. So about 15% of the cases of TB around the world are in HIV-positive individuals. TB accounts for about a quarter of deaths from from HIV, AIDS. 80% of those HIV TB cases are in Africa, and 25%, and this is a horrible figure, 25% are in South Africa. So all that stuff I told you about Nelson Mandela and Long Walk to Freedom, and then the country is suddenly burdened with this horrible problem of TB and HIV together. In England and Wales, we have also seen issues here. 3% in 1999, crept up to greater than 8%. There has been concerns that this mushroom in Western countries actually has been a contained problem, more or less, but maybe not forever. What we know is that if you give antiretroviral treatment to individuals, you decrease their risk of getting symptomatic tuberculosis, you decrease their risk of dying from that. It's unclear at the moment where on a population level, if you give everyone antiretrovirals, what effect does that have on tuberculosis control? It probably does have an effect, but we don't have the clear evidence yet. There is this strange thing of TB immune reconstitution. So if someone has dual infection, the HIV has meant their immune system smashed to pieces down to the ground. You give them antiretrovirals, their immune system wakes up again and then starts forming an immune response against all that tuberculosis in their tissues, and they can actually feel iller than they did before and get symptomatology that they didn't have before. In terms of diagnosis, well, there are some interesting new developments here. Fluorescent microscopes that have light-emitting diodes. You might sort of think, well, that's a very small kind of incremental thing, but it makes a big difference when you scale this over the world and you're trying to run a microscope in a remote area. There's a very interesting development called MODS, Microscopic Observation Drug Susceptibility Assay. Now, I work in the field of molecular biology, and we all think, oh, we're going to bring wonderful new things out of understanding genomes and all that kind of stuff. This gives the lie to that sometimes you can come up with very simple interventions that don't require any of that sophistication. What they do here is that they just culture the sputum in tissue culture plates, and they add drugs to some of the wells and not to others, and they look at the wells daily for growth using an inverted microscope. And what you can see is, if you look down the microscope, you can see the M. tuberculosis cells growing into small colonies of M. tuberculosis. And they have this typical appearance, actually. The organism that causes TB, unlike related mycobacteria, forms these long cords. So you can watch these grow over time, just looking down the microscope. You seal up your microtype dish in a plastic bag, so there's no risk to the operator, but you just put some cellophane, you look through it. And you can see these things growing within about 8 days. And if they grow in the well without the antibiotic, but they don't grow in the well with the antibiotic, then you know that they're susceptible to the antibiotic. If they're growing in the well with the antibiotic as well, then you're getting a readout that says they're antibiotic resistant. So this is a very low-tech approach that's actually being trialled in various, I think the last I heard was in Peru they were doing, or Ecuador, they were doing studies with this and showing that it really does work out in a kind of third world situation. A variety of other tests, PCR-based tests like amplification tests, a T-cell-based test, a lot of interest in this country. You can actually do what they call an ELISpot test, where you can detect T cells active against certain antigens from TB, and they seem to be more specific than your MON2 test. You can efforts to detect urinary antigen. This is a kind of high-tech approach that's supposed to be applicable in a low-income country. This is the so-called MTB RIF test. And the idea is that you can make these, you can have this as a kind of kit-based system with cartridges. You put your cartridge in, the instrument does all this PCR inside it, it makes an assessment as to whether you've got tuberculosis there, and it also amplifies up one of the genes that's responsible for rifampicin resistance and gives you an assessment of whether the commonly seen rifampicin resistance mutations are there. And this is supposed to be applicable, and it's going to be rolled out into real-world situations. And I think at the moment the assessment is that it actually seems to be quite robust and does work, and it gives you a result in less than 2 hours. And you compare that with our traditional approaches, where it will take you a minimum of 2 weeks to actually grow the organism in a conventional sort of situation. Oh yeah, I mentioned the T-spot. This detects antigens found only in the virulent form of TB, not in BCG. So again, it allows you to... It was used, there was an outbreak in Leicester a few years ago of tuberculosis, and they used this approach there, and they could actually show quite nicely that people who've been most exposed to the index case had the highest T-cell responses. Those a bit further away had lower T-cell responses, and then some people didn't have any, obviously hadn't been exposed. But it's expensive, this particular test. Right, how are we doing for time? I've nearly finished. MDR-TB is a big worry. We have resistance to rifampicin and isoniazid, two of the drugs which are very helpful in sterilising the patient, getting the patient cured quickly. We also have now seen XDR-TB, and we've seen something called TDR-TB, totally drug-resistant TB, recorded in the last year or so. And we've seen a worrying increase in the number of MDR cases around the world. There are some hotspots in the former Soviet Union, particularly in the prison systems there. We see a lot of this. See in India, this is where we saw this first totally resistant, drug resistant. Probably there is quite a lot of it in Africa, but we haven't always got estimates of how much there is. And basically what you have to do is you have to give additional drugs, you have to treat for longer, so you may be treating patients for a year or 18 months. And there are medical and legal dilemmas. If someone has multi-drug resistant tuberculosis and they will not comply with what you ask them to do of staying in a side room and they want to go home and wander around the bullring or whatever, or catch an aeroplane somewhere, what do? Do you have the right to lock them up? And this is bringing forward some very interesting ethical and legal issues here. Treatment outcomes are pretty poor. There's this particular outbreak in a place in South Africa, in KwaZulu, to gain a ferry. 52 out of 52 patients died. It was a fortnight from diagnosis to death. This is a really aggressive form of XDR-TB. These are HIV positive patients, but nonetheless, this is comparable to an aggressive cancer in terms of its, or even worse than having lung cancer or something like that, because usually you have a few months at least then. Again, there is hope. 10 years ago, people were, oh my goodness, it's all going to go bad and we haven't got anything. Well, we do have things. There's a major trial known as the REMOX trial looking at moxifloxacin, a fluoroquinolone related to Cipro that you might have heard of. This trial is ongoing. We'll know soon whether actually adding that to regimes actually gives you a better result. Some new drugs, this TMC-207, this seems to cure mice, just given you give this combination of 3 drugs once a week and you get cure in 2 months. So that would be a wonderful step forward in humans if we could just give once weekly dosing for 2 months, just 8 doses in effect, to cure someone. That would mean that it would be a lot easier to treat. There's some other drugs there listed as well that are in various phases. In terms of getting better vaccines, people are trying to add new antigens to BCG. There are these recombinant BCGs that overexpress various things, Listeria lysine, antigen 85. And there's this prime boost strategy where you give inoculation with viral vectors that actually code TB antigens. So one of the most, one that's being looked at the most is the so-called modified vaccinia vaccine, which is the old smallpox vaccine, but then is re-engineered to express tuberculosis antigens. And this approach seems to also be looking favourable so far in laboratory work and in trials. So as with malaria, we finish by saying, well, where are we at? Are we actually going to win? Or is this bacterium going to still get the better of us? So the global target of treatment success rate of over 85%, one of the targets they set for new smear-positive cases, was reached in 2007, generally across the world, but it wasn't equal. There were some high-burden countries, 9 high-burden countries, where they hadn't quite got that right. 2008, DOTS was implemented in 180 countries, 91% of those where it could be, including all of the countries, nearly 24 countries that have the highest burden. And this is where those figures that Bono was making, 36 million patients cured in that time. Case fatality rate halved. So instead of having an 8% chance of dying from your tuberculosis, it goes down to 4%. 6 million deaths averted through scaling up DOTS compared to let's just say, 1995 scenario. Global case detection rate increased 6-fold, but it's stabilised at around 60% of cases are actually detected by doctors in the healthcare system. Target of 70% was set, not been reached. It's been postponed and then not yet reached. It's not yet reached globally. So there's still too many patients out there coughing away with tuberculosis that nobody knows about. 360,000 HIV, TB patients identified. Probably about 25% of the total. But unfortunately, only a small fraction of those are actually enrolled in antiretroviral treatment. And again, we're still only really skimming the surface here. So, the Millennium Development Goal to halt and begin to reverse TB incidence is estimated to have been reached already by 2004. So we've kind of stopped TB getting worse across the world. We've put things into reverse. But we are going in reverse very, very slowly. The decline now is less than 1% per year. So it will take a long, long time before we ever get rid of things at current rates, get rid of this disease. And probably that we will meet this 2015 target of halving prevalence, but it might not be met worldwide. And we don't know. I mean, XDR-TB, is it going to erupt into our communities? Are we going to see some super spreaders spreading it and we get all out of control? We get totally drug-resistant TB? Are we going to go back to the days of sanatorium where all you could do for people with TB was tell them to go and rest and don't strain themselves and just take a bit of fresh air and all that? Or the other technique that people used to do before drugs was to actually cut out the affected tissue, so they take out half of your lung as a way of removing the most of the burden of the infection. Are we going to go back to that, or are we going to get this under control? We're not going to get to this 1 case per million by 2050, not with the current technologies. It's not going to be eliminated in my lifetime. I don't know if it will be in yours. Maybe your children's lifetimes. If you're interested in this, if I've inspired you by this talk, then, as I say, the world expert on cell wall biosynthesis, who is gearing up to bring us the next generation of drugs, is a guy called Del Bezra. And if you want to do a project or a PhD or anything like that, then he's the guy to contact on this.